disease. Previously, we take the VSD, the second lecture, if you remember, the third lecture talking about the ASD and the PDA, and today we'll talk about the last subject will be the coarctation of the aorta. بس لحظة خلي ممكن ريكورد ما سويت. So, what are the meaning of coarctation of the aorta? Meaning there is an obstruction or narrowing of the aortic arch approximately near the origin of the left subclavian artery, precisely at the insertion of the ductus arteriosus. This is the most common site for occurring of coarctation of aorta, although the coarctation may occur at any site through the aortic arch and descending aorta to the bifurcation of the iliac artery or common iliac artery. But the most common site is this near the origin of left subclavian artery, comprising about 98% of uh, of coarctation cases. These patients usually commonly presented with hypertension, and the pathophysiology there will be decreased flow from the proximal to the distal arch. As you see here, the figure and showing how the aortic arch here in A, how it is constructed, and the flow will be from the ductus, so this is the fetal. Then B, there will be narrowing, and this is will go to the C in the neonatal period, where we have beginning of constriction of the PDA, as we see here, and there is increasing of the narrowing. طبعا in type B we see here a flow from the PDA to the arch in the fetal period, while in the neonatal period will start to constrict and close, and then in D and E we'll see the closure of the PDA, and the constricted side will be obvious near the origin of ductus arteriosus. So, what are the associated symptoms or the general clinical features? Usually, this anomaly occurs as twice in male patients than female. This is one of the anomaly more common in male. On contrary to the ASD, as we said last week, it is more common in female. This type usually is more common in male. Also associated with syndromes like Turner syndromes. So many patients, they come to us for screening with Turner, come for echo to screen for associated coarctation of the aorta. One of the complications of Turner syndrome will be coarctation, and also associated with bicuspid aortic valve in about 70% of the patients. So it is common. Bicuspid aortic valve is common in coarctation of the aorta. طبعا bicuspid aortic valve احنا حكينا بالمحاضرات السابقة most common congenital anomaly congenital heart disease مثل ما قريته بالمحاضرة الأولى كان هو ال VSD about 30% حكينا عليه مو صحيح إذا تتذكرون. البايكاسبيد aortic valve هو more common than VSD بس ما يعتبر ضمن congenital anomalies congenital heart disease. فلذلك احنا بنحكي على VSD excluding the bicuspid aortic valve. It is more common in population constitute about 1 to 2% of the population. يعني كل 100 شخص عندهم واحد من عندهم أو اثنين من عندهم موجود عندهم bicuspid aortic valve. طبعا بيها complication لا تروحون تقروا في الفيوتشر ممكن associated with aortic regurg أو aortic stenosis فلذلك يحتاجون دائما screening أو echo follow-up. Mitral valve abnormality may be also associated with coarctation of the aorta, including parachute mitral valve or supravalvular mitral ring, and also subaortic stenosis is also associated abnormality. طبعا موجودة هاي patient when this group of left-sided obstructive lesion occur together we call it Chong complex. فذلك هاي patient يجونا عندهم coarctation of aorta عندهم aortic stenosis عندهم parachute mitral valve أو supravalvular mitral ring بس يعني كلها نشوفوا كلها obstruction بالايورتا obstruction بالميترال obstruction coarctation بالليفت سايد overall هذا كله نسميه شون كومبلكس. طبعا of poor prognosis difficult to treat and the patient present with systemic collapse left side كله obstructed. What are the clinical features of patient with coarctation of the aorta? This depends on the severity of obstruction and the patency of the ductus arteriosus. كل ما كان severe obstruction كل ما البرزنتيشن يكون earlier كل ما
دكتور
نعم
بس السلايد باقي على الثاني ثاني سلايد.
ايش عجب شنو
دكتور من تعرض السلايدات بالحجم الكامل ما تتحرك بعد.
هسه
اي دكتور هسه تحرك.
ايش عجب هاي ليش هيك؟
ما اعرف دكتور هي مثل كل الدكاتره جالسه هيك.
يلا هاي خليها على هذا شو اسمه بس هاي جديدة هاي الشغلة زين نبهتوني. تمام فهسه كلينيكال فيتشرز واضحة.
واضحه دكتور.
تمام. So, as we say, the clinical features will depend on the severity of obstruction. كل ما كان obstruction of the aortic arch severe, the patient will present earlier, and the symptoms will be more severe, and patient will be collapsed soon, or presented with heart failure, severe pulmonary hypertension, even one of the end of the entity will be interrupted aortic arch. يعني الارش كله مسدود اصلا. The patient depends on the PDA or maybe mild or moderate obstruction of the aortic arch. Most of the clinical features appear after closure of the ductus. طبعا احنا من الدكتس arteriosus opened the patient راح يعبر لنا blood لذلك البيشنت تكون السيمبتومز مالته less severe. When the duct will be closed after birth. We said before in the previous lecture. Usually, the ductus arteriosus normally close in the first 10 to 15 hours after birth, but in severe hypoxia may prolong the period for closure. So, if the duct will close, they will present with severe symptoms and collapse and acidosis if the obstruction is very severe. So this will depend on two types. We'll divide the coarctation into ductal dependent coarctation of the aorta, this is the infantile type we call it, and the second type will be adult or non-ductal dependent coarctation of the aorta. What about the presentation of patients with ductus-dependent coarctation of aorta? As we say, they are usually presented early in life, usually in the first 3 to 10 days of age, with features of heart failure. الهارت هذا أكو interruption of severe stenosis and pumping against a closed pipe. This will end into heart failure in a few days and circulatory collapse. The patient will have no systemic circulation, so they present with severe collapse, acidosis, heart failure, and all signs symptoms. Patient looks like shocked or septic because of severe coarctation. Especially after the ductus will be closed. The second feature will be no murmur, and murmur عادة depending on the collaterals. The collaterals will hear the murmur. So in early type there will be no murmur, but the patient, as I said, usually present with collapse and sepsis. So this is one of the indication of echo study for any unit presented with features of collapse or sepsis or shocked without knowing the exact cause for his circulatory collapse. Also, we should always check the femoral artery pulse, which may be absent or maybe there is a radiofemoral delay. لذلك احنا بالexamination, cardiovascular examination, we say always you should check the forelimbs, the upper limbs, and lower limbs for excluding of coarctation of the aorta. Usually, as we know, the femoral pulse become we feel it a little earlier than the radial artery because the pathway is shorter, usually direct. We feel it. بينما radial needs time to reach its pulsation. So this is normally we feel the femoral pulsation before the radial. While in coarctation of the aorta, because of interruption of the pathway of blood through the aortic arch, there is the femoral pulsation will become later than the radial. And in severe cases, طبعا there is absent about 40% of the patient with coarctation absent femoral pulses. طبعا هو هذا مشكلتنا احنا بالقسطرة. One of the most difficult cases is this need patient shocked, need emergency cath lab operation for balloon or stenting to open the obstruction. So the difficulty here is to have an access point because we can feel the the femoral pulsation. So احنا نقول العملية إذا حصلنا الاكسس بوينت الفيمورال ارتري نعتبر العملية انتهت. زين، لأن مرات تطول ساعة ساعتين احنا وما نقدر نحصل اكسس بوينت. البلسز تكون كل فيري ويك اور ابسنت، فاحنا نظل نشك عمياوي لحد ما نحصل الاكسس، وراها نوصل لل area of correctation. وطبعا later on the patient will develop hypertension and the blood pressure in the upper limbs will be higher than in the lower limbs. طبعا in normal persons except in neonatal period the systemic blood pressure in the legs, as you know, obtaining by a proper cuff size will be 10 to 20 millimeter higher than in the arms. Coarctation also is the commonest cause of hypertension in infant, and so when we measure blood pressure and found hypertension, usually by using the proper cuff size, which is about covering 2/3 of mid-arm circumference, you should think of coarctation of aorta. خاصة البيشنت حتى ذول الادolescent when يجونا with hypertension, usually you know it is the primary cause is more common in pediatric age group, while the most common cause of hypertension in adult patient is idiopathic. So in pediatric population or adolescent near 18, 20 years, you should dig and look for exact cause of hypertension. One of the causes is coarctation of the aorta, and this usually we do it by ourselves by by echo to exclude it, while we should look for other causes وهو طبعا تعرفوا اللي هو renal cause. فذلك أنا أجوزهم عادة على renal angiogram to exclude renal artery stenosis. This is the most important وهاي يطلعوا لنا positive. وطبعا عندنا اكو الميتابوليك او النيورو اندوكراين كوزز اللي هو تعرفوه الفيو كروموسايتوما، هذا ايضا ممكن one of the important causes you should look for in the adolescent patient with severe hypertension. طبعا الهايبرتنشن مو يعني تتوقعوا انه يجون ذولا 14 و15 severe hypertension يعني above the 20s renal artery stenosis coarctation pheochromocytoma حتى يجون above the 20s. طبعا it is important to determine the blood pressure in each arm. A pressure higher in the right than the left arm may suggest involvement of left subclavian artery. هذا السايت مال coarctation مهم. إذا عبرنا left subclavian إذا involved left subclavian فلذلك راح نشوف difference بالblood pressure between the left and right arm. لذلك هذا مهم. احنا بالcoarctation of the aorta عادة we check for limbs اللي هي upper left and right arm and lower limbs اللي هما left or right lower limbs. نشوف difference between the upper and left. لذلك نفكر بالسايت مال coarctation. While the adult type, this is the infantile type and neonatal type. The adult type usually need several years to develop signs and symptoms, and usually they discover asymptomatic by echo for accidentally sending for echo for any reason, and we find the patient have coarctation of the aorta. or checking the blood pressure of this patient and accidentally they found they are hypertensive and they send him for echo and discovering that the patient may have coarctation of the aorta or may hear a murmurs. This is due to bicuspid valve dysfunction. As we say, they are liable for developing uh, regurgitation or stenosis in the future or due to increased collateral circulation, and this will hear a murmur in the interscapular area. What about the investigation that should be done for the patient with, with the coarctation of the aorta? The simplest investigation that we available 24-hour, and you can have many information for it, including the chest X-ray, and usually inductor dependent, maybe normal, or maybe cardiomegaly if associated with heart failure. As we say, they are liable for developing heart failure and pulmonary hypertension because of severe, if have severe interruption or coarctation. لذلك احنا patient بنشوف they have pulmonary hypertension in the neonatal period. Then we look for the aortic arch to exclude coarctation of the aorta. لذلك لازم نخلي بالنا الcoarctation if the patient عنده pulmonary hypertension. Adult type may be normal or may have rib notching due to collateral circulation. هاي الريب نوتشنج أعتقد بالأول صورة على اليسار هذا تشوفوها، هاي الأسهم البيضاء شلون صاير إنه الفيسلز الكولاترالز وماكلة من الريب، لذلك كذا يشوفون النوتش شلون واضح صاير بيها. Also there is a free sign هاي يسموها بالإكس-راي اللي هي aortic arch coarctation and pulmonary artery appear as number 3. This is the picture on the right side. بيها تشوفون صورتين، واحدة تشوف النوتشنج والثانية هذا بالريد لاين نشوف شلون الأيورتيك والبلمونري وهذا النوتش بالنص، فهاي اللي مسويت لنا الفري ساين of coarctation of the aorta. طبعا وهاي اكو خاف تسمعون بيها، نزلتها صورة اللي هي reverse free اللي هو عكس الفري بالباريوم swallow. إذا تسوي له باريوم swallow للpatient for any reason you find the reverse free أو E letter in the barium swallow ونفس النوتشنج بس صاير عندنا بالعكس. طبعا ال ECG finding may be ductal dependent normal or RVH, while the adult type may present with hypertension, and this patient will develop left ventricular hypertrophy. طبعا الايكو هو diagnostic test. احنا we see from the suprasternal area we examine the aortic arch and we found the site of constriction, and by Doppler study we see the obstruction. If it is more than 20, this is indication for intervention, usually do either cath or by surgery. What are the complications of patient with coarctation of aorta? As we said earlier, they are liable to develop hypertensive heart disease and also congestive heart failure, pump failure in the early life if severe obstruction. This is the ductal infantile or neonatal type. Intracranial hemorrhage and stroke. Increased pressure may causing bleeding, infective endocarditis, and also rupture of the aorta. What is the treatment of this patient? Usually, the ductal dependent part, as we say, this patient will develop with circulatory collapse, especially after the closure of the PDA. So we need immediate resuscitation of the patient. ABC, including cannulation, IV fluid, nootropic drugs for heart failure, the patient with failure, digoxin or dopamine, dobutamine, milrinone to increase the pump of the heart, and if ventilation of the child, if he is severe hypoxic, and also maintain the patency of the ductus arteriosus. This is the most important treatment in the patient with ductal dependent lesion. Any patient, this we'll talk about it in the next few lectures, also complex congenital heart disease or DTGA, any congenital heart disease that the patient life depend on the patency of the ductus. So we should keep the patient on prostaglandin E1 with about infusion about 5 to 20 microgram per kg. This is important to keep the duct patent until the proper operation done for the patient, either cath or surgery. So the duct will not close, and the the circulation will depend on this the patency of this duct. So if you suspect any patient you suspect with cyanosis or ductal dependent acyanotic or cyanotic with circulatory collapse like this patient, if you suspect a heart lesion and you don't have an echo, you hear a murmur or something like that, and you have strong suspicion of ductal dependent lesion, you should keep the patient on prostaglandin and then to keep the patient alive, and then you can do the echo later on to confirm the diagnosis. Why? Because as we say, the life of the patient will depend on this duct. If the patient have uh, interrupted aortic arch and the life of circulation, systemic circulation, depend on the duct. If the duct will be closed, the patient will die within a few minutes. And later on, as we say, after stabilization of the patient, we can do cath or surgery for the patient. In the adult type, as we say, the pressure gradient with echo is more than 20 millimeter Hg. We do either cath or surgery. So by surgery, they do resection and end-to-end anastomosis of the interrupted arch or area of severe coarctation, while in the cath lab we do balloon dilatation and stenting of the arch. هاي picture below ده تشوفون انتو شلون هاي on the right side انه شلون لونه وداخلين احنا وهاي الاريا اوف هاي الارch وهاي الاريا اوف coarctation, while in left picture طبعا هذا more severe coarctation. هاي after بالون after putting the stent. شوفوا شلون انه تقريبا رجع للنورمال. طبعا احنا measuring الجريدينت نشوفه لازم اقل من 20 يرجع للنورمال. اذا بعده نبغى ننفخ البالون بالستنت لحد ما انه يرجع الجريدينت يكون within normal. طبعا بالبداية بالنيونيتال بيريد هو البتر هو طبعا السيرجيكال procedures, but احنا عندنا مشكلة هنا surgery weak complicated, ما عندنا good intensive care unit، فلذلك مرات تشوفون احنا نسويهم وطبعا هذا الستنت يراد يعني older age group، يلا نقدر نحط له في حتى الارش ياخذ الابروبريت سايز مالته after 2 to 4 years. لذلك ما نقدر نسوي بالنيونيتال بيريد. فاحنا عادة ندخل نسوي لهم بالون دايليتيشن ونطلع، وممكن انه نسوي لهم عدة مرات لحد ما يصير الايج مالته اكبر. نقدر عاد نسوي له سيرجري، او اذا الستنت متوفر زين after 2 4 years ممكن انه اخلي له ستنت او يرجع لايك بنورمال. هذا كان اللاست سلايد. ما عندنا شيء هذا اليوم بالنسبة للكوركتيشن أي خيارته. إذا أكو أحد عنده سؤال. الكل واضحة الأمور
إن شاء الله دكتور، عاش إيدك.
بإيديكم. ماشي، يعني إذا ماكو شيء تقدرون تاخذون راحتكم. نلتقي إن شاء الله الأسبوع الجاي ويا سينوتيك كونجنتال هارت ديزيز.
شكرا دكتور.
أهلا وسهلا، الله يعافيك.